So, good evening, everyone, and Vanakkam, Sasrikal, Assalamu alaikum, Namaskar. Welcome to each and every one of you for being here for our 7 webinar series. Today is the last day of the webinar, and thank you for coming and attending all the sessions. And all of these are getting recorded and they are being uploaded on our YouTube channel. And you can always use these webinars to educate your nurses, to have a discussion around it. So please continue to use the information shared in these sessions by infection control nurses who are trained by Signia Healthcare. And we are extremely proud to have presented the young nurses as speakers here. And thank you so much for coming and encouraging them and being very participative, asking questions and, giving your comments. Thank you very much. So this is the last webinar of the series that we had planned. And this was planned in October in honor of Infection Prevention Week. And that's how we started with the 7 series webinars. And today is the last day. Instead of 31st October, we had Halle doing the non-ventilator associated, pneumonia. Then we talked about extravasation. Then we had strategies to prevent infection in acute care settings. Then we had prevention of SSI. Then we had environmental hygiene. The last we had was on CLAPSy. And today I'm very proud to invite Siby, one of our student, of course, and she is going to talk about ventilator-associated pneumonia and the new terminologies which are being used as per the CDC guidelines. So she'll be talking about ventilator-associated events, ventilator-associated condition. The definitions are very clear as outlined by CDC. And we continue to use the word VAP in India. We know that, but yes, probably we can learn, all of us can learn together the new terminologies. So thank you and see you next time means whenever we plan, maybe next year during the infection control webinar, we'll come again. Infection control week, we'll come again with, more activities and we are hoping to utilize these recordings for the next level of learning. And we'll come back to you with those plans very soon. So thank you for being here. And let me now welcome young infection control nurse, Siby. Feba, can you come on the video, please? So that is Feba. Feba, a very, very warm welcome for being here. And I would like you to introduce yourself and then share the screen and start your discussion. And I'll ask the members who are here, in case you have questions, please continue to put that in the chat box. We'll take it at the end of the session. And I know that these many terminologies could be very new for some of you at least, so feel free. And we'll try to keep it simple and easy to understand. All the best, Feba. And I'll come back when you finish your session. Please introduce yourself. Tell them about you first and then share the screen.
Good evening, ma'am, and good evening, everyone who are present here. My name is Siby. I am working in Manipal Hospital, Kharadi as an infection control nurse. I have experience of 14 years in several, starting from the staff nurse, then coming to ICU in charge. Then since last 1 year, I am working as an infection control nurse here. So let's go to our topics, that is VAE. VAE, ventilator-associated event. So may I know who knows about ventilator-associated event, or who are there, who are listening for the first time? You can share it in the chat box.
Please do have some, feedback into the chat box. How many of you are hearing VAE for the first time? Or you can say, I've already heard about it, or you will say, this is first time I'm hearing. So can we get some answers on the chat box, please? This is not a quiz or anything. It is just a discussion. So
This is just a discussion, so we can come to know who are knowingly first times or you already know this.
yeah, some are, there are many who are saying that I know, and somebody said the first time. So we have first timers and we already have people who already know about it. Okay.
So,
Let's move.
coming to VAE, the VAE has come from the originated that from the need of systematic identity and categorized complication that occurs in the ventilated patients. So the CDC has developed this in the year 2013, which has been used as a standardized surveillance measures for the hospital to track and monitor adverse event in the ventilator patient. So this is basically nothing that before we are tracking the VAP, when anything happens at the end, we will go and survey everything. So this is a systematic way to identify at the earlier stage. Definitions. These are the definitions. We identify by using combination of objective criteria. That means whenever there is a patient on ventilator, and after that time of stability and improving, suddenly after 2 or 3 days, patient may deteriorate as per the respiratory evidence or any inflammation or infection. After that, or else any laboratory evidence of the respiratory. Then this is the definition of the VAE. So what is the purpose of doing this VAE? Is nothing to improve patient safety and reduce mortality by identifying and preventing VAE. So while doing the VAE, we will come to know at the earlier stage and we will identify what is happening to the patient, and at the earlier stage we can prevent it to the VAP. So the objectives of VAE. So why we have to do the VAE, that is to prevent the complications and to improve the patient outcomes, improving monitoring and early detection, optimizing care for mechanically ventilated patients. So if any patient is on ventilator, there may be a causative factor as well. So let's discuss what is the causative factors. First one is the micro aspiration. So whenever there is a patient on ventilator, so there is a chance of patient increase of secretions which may go into the lungs, and that is called a micro aspiration. Second is the ventilator circuit colonization. So whenever patient is on long-term patient and using the same circuit, and there is a colonization of the microorganism which may lead into lung infection. Other one is the inadequate hygiene. So if any healthcare workers doesn't do the proper hand hygiene as per the movements and step, there is a chance to get infection to the patient. Stress ulcer prophylaxis. Stress ulcer prophylaxis is nothing but any patient who are on ventilator, uh, all patients should be on antacids. If not, due to regurgitation, there may be a chance of aspiration to the patient which leads to VAE. Then oral care with clohexidine. So whenever there is a patient on ventilator, so everyone is doing the oral care with clohexidine. So with using the clohexidine, there may be a chance of normal flora to die, and maybe a cause of infection. So let's discuss what are the risk factors. So there are patients who are immunosuppressive, chronic lung disease, long hospital stay, patient who re-intubated, inappropriate antibiotic use. So what are the criteria for surveillance? So if we go and do the surveillance, not only for all the ventilator patients, there are, as per the CDC, there are criteria to do the surveillance. That is, the patient who are above 18 years, we need to do the VAE surveillance, or else the department who are hospitals or ward who are acute care, long-term acute care, or in patient rehab facilities. So in these areas, we need to do the surveillance. So in this, there are certain definitions which we are using for the surveillance. That is date of event. Date of event is nothing but the day when the worsening of the oxygenation starts. So if suppose when the patient comes on day 1, day 2 patient was normal, but day 3 patient deteriorates in the oxygenation. So the date of event will be on day 3. So that is the date of event. Location of attributions. Location of attribution means the patient, where was the patient at the time of at the date of event. Suppose patient was, as discussed, patient was on third, patient was in ICU, fourth patient shifted to ward, but patient developed the infection in the ward. The date of location of attribution will be ICU. So that is very important to know. So episode of ventilators. When episode of ventilation, episode of ventilation is what, when the patient is on ventilator for some suppose when there is a patient who is there for 10 days. After 10 days patient intubated, and there after full 1 calendar day again the patient re-intubated. So there is a new beginning of the episode starts. That is the episode of ventilator, episode 1 episode and 2 episode. So in this 2 episode, there should be a 1 full calendar day. VAE window period. VAE window period is that time when the infection has started before 2 calendar days and after 2 calendar days. So incubation period we used to say, that means when the patient, as we discussed, patient came and started the infection on the third day. After that third day, the window period will be the day 1 and day 2, or else day 5 and day 6. So to track the VAE, we have a classification. So what are the classification means? It is divided into, there are 3 classification. First one is ventilator-associated condition. Ventilator-associated condition is when the patient deteriorate the respiratory status after a stability or improvement. That we'll discuss later in detail. Second one is infection-related ventilator-associated complications, an infection that contributes to respiratory deterioration. Third one is possible or probable ventilator-associated pneumonia. This is the final stage where where we used to say as VAP. There is a clinic, apart from the deterioration, there will be an evidence of pneumonia, clinical evidence of pneumonia in ventilated patient. So one by one, let's discuss ventilator-associated condition. When there is a patient who are on ventilator, so the patient who is having PEEP and FiO2. This is focusing on the PEEP and FiO2. When day 1 patient, the PEEP was normal, PEEP was 100%. Day 2 PEEP was 100%, but in the day 3 it was deteriorated. It is decreasing by 50%. I will show you in the table. Here in the table, you can see that FiO2 day 1, the FiO2 was 100. Sorry, this is. So here it is, you can see that day 1, the patient FiO2 was normal, and PEEP was also stable. Again, day 3 and day 4, 50. PEEP was 5 and the FiO2 was 50. Then day 5 and day 6, the PEEP increased to 8. That means there is always there, we need to keep in mind that when there is a increase in 3 points from the PEEP and 20 points from the FiO2. So here we can see from the 5 it increased to 8, that is 0.3, and from the FiO2 0.20, that means 50 to 20. So it is here the date of event starts. That means the patient is classified, the VAE as a classified as a VAC. Apart from that, second one is infection-related ventilator-associated complications. So this is nothing but when there is a patient who are on ventilator, their FiO2 will be normal, and there is some deterioration in the oxygenation. And along with that, patient our WBC and temperature is increasing. Like here, table shown as like here, FiO2 was 100, then it was 50, 35 decreases. Then after 2 calendar days, is increased to 60%. Here also the PEEP is 8, 6, 5, then again it increased to 6. But here we can see the temperature and WBC also increased. And before the antibiotic was started 1, along with that again started with 2 antibiotic. 1 or 2 antibiotic. If any patient who has temperature, who has increased WBC count, along with that 1 or 2 antibiotic is going on, then we can say it as a IVAC. This is possible ventilator-associated pneumonia. It is defined as an indicator that infected might be localized to the lung. So apart from that objective data, clinical data is also it is important. So when the patient is having VAC, IVAC, after that we will go for the microbiologic evidence, that is we will be taking chest X-ray and cultures we will be taking. So in that, if it comes positive, then we can define as a patient, as patient is the patient developed the VAP. So hope you everyone understood up till here. Any doubts? Okay, so let's discuss. So let's here we can see what is the difference in old versus new. So old means VAP. So before earlier 2013, everyone was following the VAP. So why it is VAP and why it is coming to VAE? That is VAP. In the VAP, what happens? Everything patient is infected. When we will come to know at the end, when the X-ray or any cultures come positive, then we will come to know patient develops VAP. After that, what as a infection control nurse and HIC team, what they does, they will go all the backward data when the patient started, when the fever started, there starts the surveillance. So the subjective clinical symptoms increases only, then we will come to know the VAP. But in new, it is a systematic identification. As we'll this is a systematic way. When the patient is on intubator, from the day 1, we start the measuring surveillance. Then whenever there is this initial stage of any deterioration in requirement of ventilator or any objective criteria, if we find out anything, then in the same time or early detection, we will come to know with that. It is very helpful to the with the surveillance. Is there anyone who was recommended strategies to prevent VAE? So what are the strategies we need to recommend to prevent the VAE? As a nurse, as an infection control nurse, we need to do all these essential practices to prevent VAP or VAE in adult patients. That is whoever, and the second one is additional approaches for preventing VAP, VAE in adult patients. So let's discuss one by one. So what are the essential practices? Essential practices is what, which is very important irrespective of whatever. We need to do this all the practices. That means avoid intubation and re-intubation if possible. So there is any patient of deterioration or any patient who requires oxygenation. So let's first of all initially start with the oxygen, then high mask, then BiPAP, then only if it is required, only then go for the intubation. Sometimes it is it has been noticed that there are doctors who says night mein aaya hai na, let us intubate the patient and they will take rest. So that should not be happen. When that should not be happen. Then minimize sedation. Minimize sedation, which helps in early extubation. So whenever patient is on an intubator, so our focus should be extubate as soon as possible. It's not that whenever they need or whenever it takes long time. As soon as the patient is on ventilator, there may be a chance of VAP. Elevate the head of the bed. Elevate the head of the bed means where patient the head elevation should be 35 to 40 degree and to prevent the microaspiration. Provide oral care with toothbrushing but without clohexidine. As we discussed, now as per the CDC, clohexidine is not recommended, but for oral care, we can do it with the toothbrushing. Provide early eternal rather than parenteral nutrition. So whenever is patient on ventilator, so increase RT feed or anything rather than giving the IV fluids. So it will decrease the patient cost as well. Then sixth one is maintain ventilator circuit. That means as soon as possible, ventilator circuit should be changed. As per the recommendation, the ventilator circuit should be changed after 7 days or any visibly soiled. Then these additional approaches we need to do, that is consider using endotracheal tubes with subglottic secretion drainage. So there are types of ET tubes, but for intubation we need to encourage to do the subglottic secretion drainage ET tube, which has separate lumen where the surroundings of the ET tube can be taken to prevent the microaspiration. Then consider early tracheostomy. The patient who need chronic oxygenation, so we need to encourage them after 10 days, or we need to encourage them for a tracheostomy to prevent the VAC. Then consider post-pyrolytic feeding tube placement. Probiotics also we need to encourage. So there are some approaches which should not be considered as a routine part. That means oral care with clohexidine, probiotic, ultra-thin urine, polyurethane endotracheal tube cuff, frequent endotracheal tube cuff pressure monitoring. These all are of the previous, but as per the new guidelines, these all are not needed. Prone positioning, clohexidine bathing, monitoring residual gastric volumes. So before, as for the VAP, these all we were doing in the daily routine. But as per the recent CDC, it is not at all required. So monitoring and surveillance. So how daily monitoring of the ventilator patient. So how we will do the monitoring of all the ventilator patient? Can anyone say?
Can you share that how you are doing the ventilated patient surveillance? How do you monitor? Not how they are getting monitored in the ICU, but rather as a process. How do you do that? We'll answer your questions once we are done with the session. Can you tell that how do you, what is the process of your surveillance for VAE? Hello, anyone? ICU flow sheet, okay? Dr. Jyoti says that is ICU flow sheet. Okay.
ICU flow sheet.
Else? Anybody else?
So daily monitoring using VAE checklist, yes. Bundle. Daily monitoring of a ventilator patient, that means, so as an ICN, daily we need to go to a ICU. There we need to go to a same day, same timing also we need to capture. It is not that today I go in at the 10 o'clock, tomorrow I go in the ICU at 12 o'clock, and the next day I go at 3 o'clock. It is nothing like that. So same day and same timing should be maintained for all the days. Use of electronic health record to track changes in ventilator. So as per nowadays, we are having a systems where we can track the patient settings. We can get the reports, clinical reports also. So from that also we can get the we can track the changes of the patient setting. Then reporting of VA to national quality improvement programs. So conclusion of this is, so nothing. So before we are doing the VAE, as I said, so nowadays why we are doing is to early identify. So as soon as we identify early, then we can prevent to that extent the patient doesn't develop to the VAP. As we discussed in the first stage, first classification, if we rule out, then we can stop, we can prevent to go it in an IVAC. So this is early identification and intervention are critical in reducing VAE. Then apart from that, implementation of prevention bundles can significantly reduce the incidence of VAE. So as an ICN, every time we need to go to rounds. During rounds, we need to check whether the patients, whether the staffs have given the followed the preventive bundles or not. If not, we need to escalate and get it done. It's not get it done from the staff and just for the patient safety. So these all were the collected from the sheet documents, which is a combination of all the bodies, CDC and all. Thank you, ma'am. It's done.
Thank you, Fiba. And now I'm going to open the floor for discussions and questions. So first of all, I have few questions. I would like to hear the answer from the audience. So number one, are you collecting the VAE data or you are collecting the VAP data? VAE is ventilator-associated event. So that can be any one of it. It could be ventilator-associated condition. It's kind of a progressive one, that the first one is, the first one is the step where the patient needs more FiO2 or more PEEP, that is where the first thing comes in, then the second thing is when the temperature comes in, the fever comes in, and there is addition of, antibiotics. So it's kind of a stepwise definition that's happening. So I would like to hear from all of you that how do you, finally, how do you report VAP? At what level do you, that you take the final definition where it is called as, potential, ventilator-associated pneumonia. So which is, what all criteria do you include when you are giving a report on VAP? Do you track that how many VACs were there, ventilator-associated conditions were there? Would like to hear from the participants here. Hello. Culture report, straight culture report. Okay. So don't you track that when the patient is needing more oxygenation or patient's PEEP requirement is increasing, don't you try to see that whether you can prevent this patient from getting worse? Because that's a warning sign, no? Okay, some people are saying yes. So culture report should not be the final destination because that comes pretty late, right? When I used to work in ICU abroad, I remember we did not have all these definitions very clear at that point of time. But only I know that our intensivist, when they come for rounds and if they see that the patients, yesterday the FiO2 was going down requirement and today FiO2 is gone up, the PEEP is also gone up. It's a natural discussion to say that why the patient needs now more oxygenation support. So definitely we'll do a X-ray to see that, whether the patient is, so immediately we will start ensuring that the patient is not having any retention of secretions. So the staff will be on extra vigilance to do chest physiotherapy, make sure all the secretions are taken out. So even when they even start a early patch of pneumonia, that is means hypostatic pneumonia, that means the collapse of the alveoli, when that happens, our intensivist will tell, okay, you have 2 hours to bring up this lung. That's what he will tell the ICU nurses and he will walk out. So the nurses and the respiratory therapist, we will work on the patient to make sure that the collapsed alveoli, they open. So these are some of the things. So, okay, so someone, I don't know who it is that, Motorola, we are collecting BAE. Step 1 is
Yes.
VAC, step 2 is IVAC, and step 3 is PVAP. So that's good. Yes. I mean, it's very important to understand the different definitions and catch the patient the moment the patient will, and it's a very interesting data to look at it, that how many people were having that, ventilator associated condition who finally went into, VAP. It's a very good study that, the ICU nurses, the infection control nurse can, actually deep dive to see that how we can prevent it, because that's the way we can actually try to prevent the VAP per se. So, okay, for quality indicators, VAP reporting is done. It is important, yes, but discussions on the events on a ventilator patient will be done by the anesthetist. Yes, definitely, but I think all nurses, if they understand, it's an early warning sign when the patient's need for FiO2 and PEEP goes up after being stable. See, on the day one, when you intubate the patient, maybe you start with FiO2 0.6 and then it goes to 7 to 8 and then it kind of stays there at 80% or 0.8. Then the next day you are able to reduce the FiO2 and it's kind of coming down. The PEEP is coming down. Then after 24 hours, you say, oh, again, the ABG is looking bad and you have to pump up your FiO2. So that's when the alarm bells should ring. And this is what I would like to add to what Feba told, understanding definition, learning the definition is good enough. But how do we translate that into real world is what is required to be discussed. This is very, very important. I think CDC has given this definition is only because we can prevent some patients actually landing into VAP. Yes, you don't have your name here, Motorola. I'm sorry. I still have to call you by that name. Your hand is up. Would you like to share something?
Namaskar, ma'am.
Namaskar.
Good evening. Myself, Satish Balla, ma'am. I,
Yes.
I have a query, ma'am.
Yeah.
Can we added all the VAI cases in HAI?
Ventilator-associated events. See, if it is
Yeah.
ventilator-associated conditions, only VAP
Yeah.
is in the HAI.
Okay.
Ventilator-associated pneumonia is the one that is in the hospital-acquired infection. So it's a very, very good question. So you cannot put all the VAEs into that because increased need for FiO2 and for PEEP is not an diagnosis for pneumonia. So that only comes the last stage, step 3, right? When it reaches there, include that patient into your high or into your VAP numerator. So I have one more question to ask all of you. How do you collect your numerator data? Thank you, Satish, for asking that question, and the answer should have benefited all the people sitting here. How do you collect your denominator data? How do you collect your denominator data for WAP?
Ma'am, Prasad here, ma'am.
Yeah, hi.
Ma'am, total number of ventilator days in that month, ma'am.
I know. How do you get that total number of ventilator days? How do you do that? Answer is correct, but how do you collect this? Satish, again, your hand is up. Yeah. Would you like to add? From ICU manager. Okay. So from ICU manager. So what does the ICU manager do?
Good evening, ma'am.
Good evening.
Yes, ma'am. For in our hospital, we have a register, that is web register. Every
Mhm.
day I have to check the ventilator patient, and I have written the patient name and all. And during disconnection also, I put the date, disconnection date. So according to that, we find out the days, ma'am, and the end of the month.
Okay. So Kim finally is giving the correct answer. Collected at the same day at same time. This is very important. Every day, not same day. It has to be collected on a daily basis around the same time. This is very important. This is a definition by CDC. This is something that, one need to be, you cannot just tell the in charges, ICU in charges, please tell me what is the no. If you have to train them to say, okay, around, if it is 11 a.m., then every day it is at 11 a.m. that the ICU people are entering the number of patients on ventilator. It's a very simple data collection, but it has to be collected at the same time. It is for all infection control quality indicators, whether it is central line, whether it is IV cannula, because the numbers will go yo-yo at different times of the day in the hospital. So it is very important that it is fixed. So, and usually it is fixed in the morning time when the ICN is around, but ICN cannot be there everywhere. So it is perfectly fine to educate the ICU, and HDU in wherever these lines or tubes are there to enter. This is very important. The answers is good, but then it is, so somebody is asking, please can you explain the reason for same time? Now, why the reason is very important. All these indicators are supposed to be matched with somebody or the other. CDC must collect the right data from different hospitals. So let's say that hospital A is putting the denominator at 11 a.m. in the morning, and hospital B is putting the denominator at 11 p.m. in the morning. So the data is not comparable. The WAP is an outcome event, so that can come whenever it will come, But the denominator, how many people are on ventilator, you have to collect, just like your midnight census. We are collecting the census at midnight just to make sure that we have the correct patient days, right? And you know that the midday census is very different from midnight census. So comparison of data is relevant only when the numerator and denominators are fixed. If patient is on ventilator for 1 hour, should we count that for total ventilator days? No. FIBA mentioned the patient has to be on ventilator for 1 full day. So in India, we are still not very standardized when it comes to the definition of hospital-acquired infection. A lot of hospitals are going by 48 hours, but CDC talks about 2 calendar days. For WAP, it is, once the patient is, intubated, and the moment the event will start, right? Infection will not come in the patient as soon as you put the tube. That's not the case unless you are intubating the patient for pneumonia itself. So that is why the definition of 2 calendar days, that 2 calendar days would mean it has nothing to do with hours. It is to do with the days only. I hope that is kind of clear, but in India, it is a little bit of confusion because the clarity on these things are not absolutely, it is not there. People are like, kind of, okay, I get some numbers, I put it there and I calculate. So the ICNs, my request is to the infection control nurses to ensure that you educate the people who are participating in data collection to make sure the data is the correct data. Otherwise, the numbers that you calculate, whatever rate you come out, will not be comparable. So let's say NABH is asking you to send data on VAP and CLAPSI and everything. But if your numerator denominator is, running around in different hospitals, even NABH cannot compare data. And same thing within your hospital, when you're doing the VAP rate for SICU and MICU, if their denominators are not collected in the same manner, you cannot compare the rates. How will you say that it is 1.2 per 1,000 ventilator days? Because your denominator has changed. So it is very important to keep that in mind, that I'm not saying the ICN has to be everywhere to collect. No, that's not a practical solution. If you have, what you call app-based or EMR-based, that's how the EMR is now being trained abroad, that, they will collect data directly from the electronic medical record at one point of time. Program is written. So at that particular time, it will capture the data that at this particular time, there are X number of patients on the ventilator. So that's the power of technology. That's where the AI comes into play. But in India, many hospitals will not have that kind of an access to, because, if that can only come if all these things are being entered into the medical record, electronic medical record, because then it can save a lot of time. Because you are saying that patient is on central line, because you're doing assessment, you're entering there. So if the inputs are all there, AI can definitely help. I mean, this is very important. So, okay, no, it won't be included. Thank you, Ashwini, for explaining that. Why are we emphasizing on subglottic ET tube and not checking on cuff pressure on regular intervals? Now, these are all evidence that CDC gathers, and they talk about evidence that, 1A to subglottic is because, the micro aspirations. The micro aspirations can be prevented if you are able to do subglottic suction. And this is an evidence that is available from CDC. That's why we depend on international bodies to tell us what are the guidelines, because they all come from evidence which is available, and the minor aspirations, which you are not able to see. What happens when a patient has a lot of secretion? You will hear the sound, your cuff pressure will increase. But then this subglottic, aspiration, the little secretion that gathers there, it can trickle down because you already have got a incompetent vocal cord because your tube is sitting there. And equally important is cuff pressure. We know that we had to manage. When I worked in the ICU, we did not have subglottic, suction, but we were blindly doing them. But then we always relied on the cuff pressure. Cuff pressure is also important to maintain, though it is not part of the VAP bundle, solely because the research has not found high level of evidence. That's why you will not see that. But personally, I know that in Indian setup, maintaining the cuff pressure is important, because the adequate cuff pressure and inadequate cuff pressure, they both have, if the pressure is too high and if the pressure is too low, they both have, got, complications. So one should be looking into that. Okay. So I will always say that please don't say that only subglottic is good enough. What is the use of doing suction and leaving an incompetent cuff? Then you are saying that, we are still allowing micro aspiration. So cuff pressure is also equally important when it comes to patients who are mechanically being ventilated, apart from your ventilatory issues that can come, because you need a good cuff pressure maintenance to ensure the patient is getting ventilated well. Yeah. Okay. There was someone who asked a question that why brushing is important. This brushing thing was there for many years. It has got its own challenges, I understand. When this was introduced, we used to get set from Kimberly Clark, when I was abroad. Definitely you need 2 people and you need Yanker suction to make sure that somebody's keeping the Yanker suction continuously, and then you are able to brush and use the syringe to flush, and you keep on suctioning because you cannot do that alone. And if patient has got dengue, obviously that's a clinical condition. The patient can bleed, so obviously you will go for something else, because we are not talking about separate diagnosis. With the patients who have got coagulopathies, obviously you need to take care the general, the nursing care to ensure the patient does not bleed, which includes even for a non-ventilated patient. If patient has got coagulopathy, any bleeding tendencies, this is one of the patient, education to say that please don't brush your teeth, that and use very, very soft bristles. Okay, so I think that I have answered. If patient comes with ET tube in situ from outside hospital after 2 days of admission, patient developed VAP symptom, should we take? Of course, yes. A patient has come from with the ventilator after 2 calendar days. Within those 2 calendar days, if patient develops any symptoms of VAP, it is a outside VAP. But anything after 2 calendar days becomes the hospital's ownership. This is important. When you learn location of attribution, you will learn, see, ICNs ideally should be also collecting data, which is called location of attribution. Where does this particular, so what happens when you are collecting data? You're actually putting, let's say I had 3 VAP. Location of attribution for each VAP. So this is where the symptom started. So that would mean 2 calendar days. So even within the hospital, location of attribution is a principle that you need to follow, because this is explained very clearly by CDC. I don't expect all the nurses to, learn this, but you must understand. So the ICN must not mix up this knowledge. This is very important. So a patient comes with ET tube from outside, and then the patient is in your hospital, but within 2 calendar days, patient develops symptoms of VAP. Then the location of attribution is the facility from where the patient came. So it is not your hospital acquired VAP. That's what, like Satish asked, whether it will become part of the hospital acquired infection. No, VAP can be your own hospital acquired infection, or it could be something that comes from outside. I hope we answered that question, Srilata. So obviously this patient will not be included in the high, but you will include this in the VAP, but not for your hospital acquired infection, because you have to know. So all infection control quality indicators, whether it is CLABSI, VAP or COTI or SSI, SSI of obviously the patients are operated in your own hospital. All the other, if the lines they come and they develop, you should have the data that the patient developed VAP. Then you will segregate them as hospital acquired infection or they are from outside. So data collection and then stratification is very important. No, blindly we should not do that. Oh, okay. Nowadays, Indian setup did not maintain many of the hospitals' nurse-patient ratio. How it is affecting effectively VAP preventing methods. So, see, nurse-patient ratio is one of the concerns, because if the nurse has got multiple ventilator patients, then there is a challenge that there could be suboptimal ventilator care. So that remains a challenge, but obviously everyone knows that it is preferred that the patient is on ventilator. They should have 1:1 ratio so that the nurse can look after the patient correctly. But if there are challenges around staffing, it is for the individual hospitals to plan what are the risk mitigation methods. So the nurse-patient ratio will not prevent VAP. Even if I give 1:1 ratio to a patient with ventilator, it is not a sure method of preventing VAP. What happens if that nurse is not practicing the right things? Patient will still get VAP. So it is very important to remember that, you will give the right ratio, but practicing the right thing is even more important. Just for everything, we should not say it is the ratio, because it is the practices of the nurses. So that's important. Okay. I think we have one more question. How long can be used one Yanker suction? One Yanker suction, it's one-time use. It is a one-time use. This Yanker suction is just like your suction catheter. Suction catheter is also single use. So your anchor suction also should be only single use. At one point of time, suction catheter, we say that you can do 3 passes. 3 passes means 3 times if you are using open suction. And the duration is 10 seconds. This is as long as you will hold your breath, that's how long is 10 seconds. Unless the patient is, having severe, like pulmonary edema, fluid is flowing out, then there is a possibility that you may have to do a slightly longer suction, otherwise 10 seconds. So any suction, whether it is Yanker or your regular suction, it is single use. You may decide to reprocess the anchor, because anchor could be a little bit more expensive, and so you may reprocess. Then you should have a reprocessing policy as per NABH, how you are going to clean, how it will be ETO'd and packed. So once opened, anchor will be used once. I hope I have answered that question too. There should be no confusion in our head. These are some basic principles. So there is no need to think beyond it, because these are very clear guidelines available. Okay. Anybody else? Thank you so much for all the, questions and answers people are giving. I'm very happy when you people come here and start discussing and clarifying things, I'm really hoping that this will all lead to safer patient care. So we have another 3 minutes more. So if you have any more questions or any comments, please, I hope you found these sessions useful. Did you find the session useful? We would like to say thank you to our young speakers, for coming here and sharing their, knowledge and taking effort to come and share. And Signia Healthcare and Nurse India is giving this platform so that our future gets brighter, right? Okay. Thank you for all of you for being here. And all of them are getting, recorded, and we will be uploading that. So I'm having some idea, what am I going to do with the 7 webinars? What should be the next step? So we will come back to you, because I think we have to find a way to spread this message more among our nurses. So let's see what we are going to do. We'll think about something. Yeah. So Feba, a lot of thank you.
ma'am.
Thank you very
Ma'am,
much.
for your support, great support and guidance. Because of you only, we could get this platform.
No, I think it's my responsibility and duty to ensure the future leaders get the voice and the platform. And thanks to all the technology, because of Zoom, we all can be where we are, and we just put in some extra effort and come and I'm very proud, because all of you have been trained by me, and I feel
Yes,
very
that's a
proud to
great
showcase
thing.
you guys here, that's a proud moment for me. So great, and thank you so much for so many people for joining us, and hope to see you all in some other sessions soon. And thanks for all the people who asked the questions, shared their, experience. Thanks again. Thanks, Satish, for being here and, being participative. Bye-bye, everyone.
Thank you, everyone.
Bye. Bye.
Thank you, ma'am.